Dr. Dinesh Banur. Dr. Dinesh Banur has a very long experience in pediatrics, more than 20 years now, with an interest in gastroenterology. Dr. Dinesh is a consultant and division chief of pediatrics at Yas Clinic Group in Abu Dhabi. Dr. Dinesh is known here in Abu Dhabi as Elon Musk of Abu Dhabi. So please join me in welcoming Dr. Dinesh.
Thank you. Good morning, everybody, and thank you for having me here. At the outset, I would like to thank the organizers and my dear friend, Professor Migdadi, for giving me an opportunity to talk on this platform. It was lovely interacting with you all yesterday. So this is where I practice. So over the next 20 minutes or so, okay, so over the next 20 minutes or so, so I will focus a bit on definition of constipation, its burden. How do we classify constipation? I know most of you are champions treating constipation. So I'm going to more focus on how do we manage when the constipation becomes refractory. So how big is the problem? The constipation is a global problem. And back in the days, maybe 2 decades ago, we did not perhaps have a proper definition of constipation. So anybody who had a difficulty in defecation, struggling to pass stools were considered to be constipated. And if you looked into the data of those group of patients, they were variable. And that's why if you look into the incidence of constipation, it varies anywhere between 0.7 to 29% or maybe 30%. But however, by and large, we all agree at least 30% of the children in our clinical practice are constipated. So there's no gender variation. And initially, it used to be thought the disease of the developed world. And I don't think we all agree that it affects everybody. And there is an exponential increase in the rate of constipation. And I'm sure you all have experienced the pandemic situation. Being more sedentary at home, online schools, the constipation has increased in n-folds. And it causes a significant burden to the family and society and the healthcare system. So constipation can be so distressing to the families at times when it becomes refractory that parents really don't know what to do. They shop visiting physicians. And at times, you will not be surprised that parents often resolve to travel to different countries to seek medical tourism. But one of the common myth about the constipation is people think that having constipation is something, a normal variation, which probably get better with age. So over the last 2-3 decades, maybe 2 decades, we have got a better understanding of the definition of constipation through a Rome criteria. So the Rome came up with how we should define the constipation, and then subsequently it has refined over the years. So then we came with 1, 2, 3, and recently we have the Rome 4 criteria, which defines the constipation both in toilet trained and non-toilet trained children. However, there is no clear-cut definition for what we call it as a chronic refractory constipation. So the data is very scarce. We really don't know how many children will become chronically constipated. So what is thought refractory is as somebody who is on a maximum laxative therapy or who require daily rectal stimulation in the form of enemas or suppositories to pass stools for more than 3 months. However, there is a little catch here. What we don't know is what is the kind of a laxatives we should choose and in what order. So that is the problem. And that's why the definition is not very clear. But this is quite an arbitrary reason. We heard about IBD yesterday, and we as GI people, we know that IBD causes a significant stress to the families, but constipation is not any different. So significant amount of the children with constipation develop severe stress and affects their quality of life, which is more or less very similar to what we experience in IBD. And the parental stress run very high whenever the children get chronically constipated. So constipation can cause significant impact to the family and the patient. It can cause social withdrawal, low self-esteem, school absenteeism because of the fecal accidents. They cannot come off the pampers, especially with children with anorectal malformation, leading to significant stress both to the children and to the family. So now, if we try to analyze, I try to make it more simple and try to analyze what causes the refractory constipation. As we all know, by and large, the most common type of constipation is functional constipation, at least 90%, and thankfully. And the second common cause of constipation is organic causes. However, both of these kinds of a constipation do get refractory for its own reasons. And let's analyze one by one. And because this is very important, because when we start counseling the parents, these things needs to be kept in mind. So why do functional constipation become refractory? The most important reason that lies is in the pathophysiology. So what is this pathophysiology we are talking about? We all know that constipation is a vicious cycle. At some point of time, when the child didn't drink enough water, fruits, or vegetables, the poop will become hard and leads to painful defecation. And this painful defecation leads to withholding. And this withholding leads to further constipation. And over the course of time, this becomes a cycle. And why this is important? So this is important because once you achieve this kind of a withholding pattern, it leads to increased rectal compliance and decreased motor function. So this is very important then that when we address the treatment for the patients, it is very important that we explain this pathophysiology to the parents so that they understand the importance of it and the importance of treating it early. It's a very nice paper that came from Benninga. So they found in the study that at least if you don't treat constipation for at least for 3 months, any delay in the constipation can lead to a lifelong problem. So we should recognize the constipation early, we should take it seriously, and we should treat it optimally. So there are other reasons why some children with functional constipation fail to respond. So one of the reasons in this part of the world is because there is a myth about addiction to the medications, and parents do not want to use this medication for the longer duration of time, and they do not want to use the optimal doses. Physician has got a gap in the knowledge about being quite aggressive and going into the optimal dosage, adjusting the medications and titrating the medication with the very early stage so that we get an optimal response. And then there is no close follow-up. So constipation is a chronic problem. And just once the constipation has started, and when you have started treating the child, it is very important that you ensure a very close follow-up, at least in the first few months of treatment, because this is equally important so that there is adherence to the therapy, the doses are titrated, and the child is optimally treated, and parents are educated. So if you look into the laxatives, Espagan has recommended a lot of laxatives. There are stimulant laxatives, there are stool softeners. There is no, but the problem is there is no drug in order which we need to use. There is no recommendation that is one drug that needs to be considered or what is the optimal dosage. So if you come to if you have a child with a constipation in the city, and if you come to Professor Migda this way, he would give milk of magnesia. And maybe if you come my way, I may consider polyethylene glycol, or somebody may consider lactulose. So there is no optimal kind of order of choice so far in practice, although we know that different medications are available. So these are stimulant laxatives which can be used on the dose provided. And then I was talking to you about the compliance. So some of the times, the children does not want to take the medications because they find the taste is not helpful. They don't want to drink mixing with water, especially with the polyethylene glycol. They don't want to take the quantity of the syrup. So there are options you can consider. So for example, you have a senna which comes like a chocolate, which can be taken like a Kit Kat. So which probably perhaps will increase the compliance. So these are many ways we as a physicians can think about and making the child compliant to the therapy. So what about the reason for children, organic causes for constipation? So this slide more or less summarizes at least 90% of the reason why children have an organic problem. So it could be a spinal related problem. It could be a disease like Hirschsprung's disease, celiac disease, the cow's milk allergy, or colorectal anomalies. So some of these are maybe a little bit more easier to diagnose because there are other associated symptoms with it. For example, if you have a cystic fibrosis, you have a weight loss, you may have a faltering respiratory symptoms. If you have a celiac disease, you may have other related issues. Spinal abnormalities can be picked by physical examination. So some of these organic causes are more easy to pick up. But there is a group within the organic causes, which is the motility disorders. The motility disorders, as you can see, there are of three types. One is a slow transit constipation, dysenergic defecation, or maybe achalasia of the sphincter. So these were probably perhaps in the past less addressed because they were all thought that this probably occurs in adults. But now we have started to realize that these kind of colonic motility disorders do occur in children. So I will just go through over the next few minutes about the most common motility problems and how do we address it. The slow transit constipation is a type of a constipation where your colon is very lazy. We don't know exactly why this happens. We think that it's probably related to the neuromuscular related pathway. The problem with this kind of a constipation is these children tend to have a lifelong constipation, starts very early. They defecate very infrequently, but when they defecate, it is soft. So how do we diagnose this? We diagnose by transit studies. Sometimes we may need a colonic manometry. And this kind of a constipation is quite challenging and difficult to treat. So some of you may be aware and already practicing this. We have got the colonic transit marker studies where you give a radio-opaque material where the child swallows, and then you take the X-rays as per the protocol, and then see how this the radio-opaque markers transit throughout the colon. So if we expect by 5 days most of the transit markers to be cleared, but at times, as you can see in this slide on your right-hand side, it is diffuse all over. That means that the whole of the colon is slow, or it could be a segmental. You can see in one of the slides, it is just, all the slides, all the markers are located in the sigmoid part of the colon where it is segmental. So based on this, we can decide whether the colon is slow all over or it is a part of the colon that is slow. The next part of the